I'm Dr. John Kruse, and today I'm going to be talking about what is ADHD. So as customary with this channel, I'll start with a take-home message that's a few minutes, and then after that, I will launch into the main message. So the take-home message is that ADHD is a neurodevelopmental condition arising in childhood and most often persisting through life that involves differences in executive functioning compared to the general population. And executive functions include such things as selective attention, working memory, impulse control, emotional regulation. And again, these are different than the norm. Some would say impaired. And the other factor about all these executive functions is that they neuroanatomically primarily seem to be contained or deal with the prefrontal cortex, and we know that dopamine and norepinephrine neurotransmission are important to these processes. Whether ADHD is a disease or a condition is somewhat a matter of semantics. The DSM-5, the Diagnostic Manual, lists it as a disease, and it's commonly considered as such. More often, I refer to it and consider it as a condition for a couple of reasons. One is it appears across a spectrum of severity, and where we decide it is a disease or just a normal impairment or normal part of range of normal is a somewhat arbitrary distinction. Also, there's other reasons, one of them primarily being the people who have it seem to prefer the language of a condition versus a disease, because condition is much less pejorative than disease. And this is clearly a neurodivergent condition. It has to do with how brains process information differently. And that comes to a second important point, that although online and even in the doctor's office now, you may find yourself subjected to checklists of 18 different symptom questions, and the checklists are used for screening tools and for diagnosis. Fundamentally, checklists are about the content of what you're thinking or doing, whereas ADHD is fundamentally about the process, how the brain works, how it is processing information or not processing information. And you can't obtain that answers to how a brain is working from a simple checklist. So context is important, the history, the trajectory, when and where symptoms occurred, what makes them worse, what functional impact, what emotional impact this has had on the person's life are important to assess. And the other crucial factor about ADHD is, and there's a fancy term for this, there's nothing pathognomonic, which is as difficult to spell as it is to say. So pathognomonic are characteristics that are specific to a certain disease. There's nothing pathognomonic to ADHD. So every single behavior that is used to make an ADHD diagnosis is something that at least some people do some of the time, and most of us do some of the time. So it is the frequency, the intensity, the extent to which it causes distress and impairment in the world that make it a condition worth considering. With ADHD, those are centered on two clusters of symptoms, one inattentive and one hyperactive and impulsive. And we'll get into that in more detail. And I'd say fundamentally there are 7 different groups of people we have to consider when we're considering what is ADHD and who has it or who doesn't. One is the classical ADHD, which I've just outlined above. Group number 2 are those who have subsyndromal ADHD or subthreshold ADHD, where they're not meeting full criteria at any one point or at a given point in time. But if the situation changes, if there's more demands, if there's less structure, if something else goes on, then they may be pushed into full-blown ADHD. And actually, some recent data suggests that that actually is more classic than the classic pattern or typical. Then the third category is what people call secondary ADHD, and those are people who had no particular signs or symptoms of ADHD until something happened, either head trauma or post-COVID. There's a few other things that might do it, that then create, usually in adulthood, a complete range of ADHD symptoms. And I put secondary ADHD into 2 separate categories, one where that appears to be permanent and ongoing, and one where that's just transient and the person does recover. So those are up to 4, so 5. Number 5 are people who have collections of ADHD symptoms, which are clearly, or upon investigation, are clearly attributable to another condition. And that other condition might be depression, PTSD. It might be post-COVID syndrome. It might be poisoning or contamination with a substance. So there are other conditions that mimic ADHD. Currently, our nomenclature says, well, those are aspects of that other condition. I think we will wind up changing that in the next few years, that if you have the symptoms of executive function problems that look like ADHD, then it's ADHD, and we should be changing it to say not that it's ADHD in this person due to depression or due to PTSD, but we're not quite there yet. Category number 6 is people who don't really have ADHD at all, but again, just have 1 or 2 of those behaviors on a certain day, so they are solidly in the normal range of what's normal, but they're having a bad day, a bad moment, or they're just curious or more overly introspective or worried about their health. So they're concerned that they may have ADHD, and I have talks also that our whole world is moving in a more ADHD direction. And then the 7th category, which lots of the media likes to run with and highlight, and some segments of the research community do as well, those who are faking ADHD symptoms for gain somehow, and it's often accommodations in school or work or access to stimulant medications. I'll just leave it for now and say that most of those people probably are on the solidly on the ADHD spectrum to begin with. So the relative numbers of people in each of these categories, I'm not going to make any comments on, but all of these can look like ADHD. So that's the take-home summary, maybe a little longer than I wanted. In more discussion, so our current diagnostic Bible is called the DSM-5, the Diagnostic and Statistical Manual. We're on the 5th version, I think 5R or 5T now. And it lists 18 different symptoms. 9 of them are inattentive, 9 of them are hyperactive or impulsive. And you only need 5 of those to fulfill, as an adult, to fulfill the criteria for ADHD. And lots of the symptoms, and I'll run through them quickly. I won't spend a long time on each one. There's a lot of overlap. So if you are positive, if you fulfill criteria for one, you're very likely to meet at least some of the others. In addition, you have to have these symptoms before age 12. It used to be before age 5, but lots of people can't remember back that far that clearly. You have to display these symptoms in multiple different contexts. So again, this can't just be a single episode or a single situation, particular social context that is driving this behavior. This has to be replicated in multiple situations. Now, that does not mean you have to display it all of the time. And one of the things that's characteristic of ADHD is consistent inconsistency. And that really throws people because they expect, well, this person has trouble, they think, concentrating or paying attention, how can they be raptly taking notes during organic chemistry class? Well, if that's really fascinating to them, they may focus really well there. They may hyper-focus or do well. So the executive function issues or the symptoms listed in DSL have to be impairing or distressing. And a couple points worth making note of is that ADHD is separate from intelligence. I do have a talk on that. So there are very smart people with ADHD. There are not so smart people with ADHD. Having intelligence, at least right now in our society, can carry people a pretty far distance and can excuse or help them circumvent many ADHD symptoms. So many bright people, it may not be detected till later in life. So I've had lots of people who came in and said some version of, their doctor told them if they were an architect or a lawyer, they couldn't possibly have ADHD because they couldn't have achieved that. But I've had doctors who mused it to me that they wondered if they had ADHD, but they couldn't possibly have had ADHD if they got through medical school. That's simply not true and not reasonable. So again, this is not the same dimension as intelligence. It can make it more challenging to achieve these goals, but it doesn't preclude them. So someone can have substantial impairment and have substantial successes at the same time. So one group that's recently done factor analysis on the 18, so most of the checklists you see are composed of 18 different questions. I'll ask, do you do this? Do you have trouble following directions? Those are based on the 18 symptom criteria of ADHD. Important things to say is that this is not a perfect list of 18 symptoms. Again, there's extensive overlap. There's also things that are left out, so there's not much attention paid among any of the 18 to time management. That's disrupted in many people with ADHD. How they sense and monitor time is different. How they prioritize, how regulation of emotions is completely left out. The fact that most people with ADHD have circadian rhythms that are substantially delayed relative to the non-ADHD population. So a group that's done some factor analysis found that of these 18 symptoms, the two that seem to be most characteristic or of ADHD and maybe help separate it out more from other conditions and are emblematic are the distractedness of the inattentive symptoms and the fidgetiness of the hyperactive symptoms. So 9 inattentive symptoms, and I'll run through the single one name. I'll expound on the name. So there are 9 inattentive symptoms. They lumped as details, span, listen, follow, finish, avoid, lost, distracted, forgot. So details is people who have trouble keeping track of details and may get the general gist of what's going on, but they may make lots of mistakes because they're not paying attention. Span is having trouble paying attention for a span of time or getting engaged in projects that are going to take considerable attention span of time. Listening is not listening or paying attention when it seems that someone is speaking directly to them. Follow is for not following up or carrying through on initial projects that have been started. Finishing is, again, clearly overlaps, but not completing projects that have been started. Avoid is avoiding starting or engaging with tasks that are going to take excessive mental work. Loss is losing things frequently. Distracted is being distracted. Forgetting is forgetting things that you've been told or thought you knew and then didn't have that information in the context you needed it. So of the 9 hyperactive or impulsive symptoms, an important thing to note is that these ADHD was originally defined and diagnosed and described in children. Many of these 9 symptoms for hyperactivity, impulsivity fit well for children, but need to be adjusted somewhat for adults. Many people claim that adults outgrow their hyperactive impulsive symptoms. It's not what I see. I see substantial changes, but many adults, so they're fidgeting, seated, run, noisy, on the go, talk, blurt, wait, interrupt. So fidgeting, they are fidgeting. They're moving their hands, they're clicking their pencils, they're hitting things, they're bouncing things, often annoying to others and that they're oblivious of. Seated is that they don't remain seated in situations where they should. Run is that they're running around and not sitting still. Noisy is that they are having trouble playing quietly alone. A different version of or aspect of noisy is I've seen many people with ADHD who start talking louder when they get noise. Lots of people when they're agitated. But it's not just with anger for many people with ADHD. They seem less aware of their own verbal presentation. On the go means that they're always moving, always either internally feeling like they have a motor inside or act like it. Talk is talking excessively. It's hard to shut them up, cut them off. Blurting is they blurt out comments where, and often in retrospect, they say, oh my God, I shouldn't have said that. I know I hurt that person's feelings. I know the boss is not going to like hearing that. Wait is having trouble waiting, and interrupt is interrupting people, cutting them off in conversations. As I mentioned, Important executive functions that are characteristic of ADHD are left out of this list. It's not a perfect list. But again, the most important problem with the checklist approach is that ADHD is much more about the process, how your brain is dealing with information. It's not the specific example of, was Jill 15 minutes late every day for work? Or did she blurt out in most of the group meetings comments that undermined her own team? Those are symptoms that can support the diagnosis, but actually watching. So an evaluation of someone with ADHD involves checking whether the way they're delivering the information is consistent with the content of that information. If they say they list off 11 of the 19 points in a systematic way and say, I have this and this and this and this, and don't lose track and don't double back and don't try to over-explain any of them, then the assessor should at least be noting that there is a discrepancy between, they seem actually very organized and able to present in a logical, linear, coherent manner, and in contrast to what they are, the content that they are reporting. Other problems with checklists are, a lot of them are due to self-assessment, are based on self-assessment, and none of us can see ourselves perfectly. Our eyes are here, can't see the back of our heads at all, and it's even harder to see inside our own heads and the back of our heads. But how we are coming across to others, we may have some idea, we may have extremely accurate idea, we may be completely projecting our own worries, fears, confidence, whatever onto others. So part of that makes it valuable to have a second person evaluating whoever is questioning their ADD-ness. Could be a professional, it could be a friend or a family member. Furthermore, and this always sounds a little pejorative, we know that ADHD itself leads to less accurate recall and less accurate observation and retention of information. So the person may not even be aware they were cutting others off, or that they were speaking too close, or they were standing in a different way. And they may have trouble recalling it even if they were aware in the moment. Furthermore, most people don't have a good idea what normal is in terms of how much normal is. When do people blurt out? How often do they do that? How often is any fidgeting present? Now, so all the criteria for ADHD are written as objective variables, objective symptom lists. And the challenge there is that, yes, most clinicians should have training on what is normal for that person's age. I didn't mention that earlier. So these are always age contexts, so you're not comparing a 6-year-old to what 10-year-olds should be doing. But most people have a vague idea of what normal is, and if someone's way at one extreme, they can say, yeah, that's way out of line. But most of the time, therapists or evaluators are doing it. They don't say, oh, that person went off track 6 times in a 20-minute discussion of point X, and only 4 or fewer times is normal, and this is objectively. So very often, even though the criteria are objective, we're using our subjective sense whether someone fits it. I think one of the ways we're going in the future, and I think already big tech, that Google's soft AI company is already measuring our voices, our interactions, our eye movements, what's going on in the background, who we're talking to. They already know how often we make stupid mistakes. They already know what we're paying attention to. They already know whether we're blurting out and whether that shuts other people down. So they have objective metrics, probably on many of us, of how closely or how far from norms we are and whether meet criteria for ADHD. Right now, most of that is not being employed by most ADHD systems. And again, moving beyond checklists of those 18 behavioral symptoms, you need to be taking a history. Again, we are assessing people. We're not assessing just lists of symptoms. And one of my regrets is that As we get more and more symptom checklist oriented, the doctor's paying attention to the list. They're not even looking at the person in the room. And even the history taking is becoming that. So you're not listening to a person. You're just saying, oh, did you take more than 4 years to graduate from school? Did you move around a lot? Did you do X, Y, or Z? And I'll just use a made-up example to illustrate that point. So if your history, you learn that your person you're evaluating took 8 years to finish college, and they went to 3 different schools before they got their degree. And you'd say, yeah, that sounds like ADHD. It certainly matches a possible ADHD trajectory. And if you don't know more information than that, so, it would match if an ADHD picture, if they switched their major 5 times and that was part of the delay and they got kicked out of one school because classmates were buying their Adderall from them, then I'd say, yeah, that's really strongly supportive of ADHD. But if you have just the same history that they took 8 years and went to 3 different schools, I had another patient from a East Asian family. Their dad died freshman year of school. Their family, they were the oldest son. They were required to come home, help mother try to get the family business back on its feet. In a few years of working very hard, they had time to go to night school. So that was their second college. And then a few years after that, a cousin came over to help run the business with mother, and the business was doing well enough so they could have funding to go to a more prestigious school farther away. And so that person's history in the checkbox, it still took them 8 years and 3 different schools. That person had no aspect of ADHD in it, in their history. It was more an example of perseverance in the face of big obstacles. So even with history taking, we should be listening to what's going on with the person and the trajectory there. And again, with ADHD, its characteristic is getting off track, not following a linear process, having barriers, particularly when there's less support or increased demand is placed on someone. So what causes ADHD? And right now, again, these are all supposed to be overviews, so I'm trying to get through it quickly. We don't know for sure. We know that most people who have ADHD have a strong genetic predisposition to getting it, and that genetic predisposition is polygenic. Many, many, many genes added together contribute to increase your likelihood. They do not dictate it. So even someone with lots of genes pushing them in that direction doesn't necessarily have it. And it doesn't mean that if you have a low gene score, you will never get it. Clearly, environmental matters do too. Things like fetal alcohol, lead or alcohol exposure in early life or in utero increase the likelihood of having ADHD. Again, most of the focus in ADHD has been on prefrontal cortex. Certainly other regions, deep brain structures, the thalamic structures, back of the brain, your cerebellum are involved. So I'm not saying this is only a prefrontal cortex, but much of what goes on with the executive functions is prefrontal cortex related and separate from being vulnerable to lots of genetic influences. Prefrontal cortex is vulnerable to anatomic trauma. So it's a big chunk of real estate right there at the front of the head. It's the leading point, so more vulnerable to hits and concussions, since lots of the damage of concussion is coup and contra coup, so the bouncing back or the head. And even more importantly than that, probably shearing, twisting forces. It's very long fibers relatively within the brain projecting to the prefrontal cortex. That makes it anatomically more vulnerable. And neurochemically, and I have a whole talk on this, so I won't go into it in detail. Glutamate, which is the excitatory neurotransmitter, most prominent of all transmitters of any type in our brain. There's a certain subtype of glutamate receptors called NMDA, and those are more susceptible to stress or flooding and can temporarily turn off parts of prefrontal cortex if too much norepinephrine or dopamine is around, and in the long term can wind up rewiring and weakening prefrontal executive function circuitry. So quickly flashing onto treatment. So I do have multiple talks on treatments of different chemicals, medications, conventional accepted ones, some supplements, other things that are not mainstream yet, but may be helpful. Also, cognitive behavioral therapy I'm a fan of. So treatment, the summary is most of the treatments to date are drugs that boost norepinephrine or dopamine, with the stimulants showing the largest effect size, so help the greatest proportion of people, help people to the greatest extent. They don't work for everyone. They do have their own side effects, particularly cardiac risks, particularly addiction, and particularly psychosis are the much less common but extremely serious potential side effects. I have talks on all of that. We do have other agents such as Guanfacine, which acts on alpha-2 norepinephrine receptors and probably helps by modifying the alpha-2 receptors that are on glutamate neurons in the brain. Certainly, cognitive behavioral therapy, I have a talk on that, and meditation, exercise are all helpful for ADHD. And I'm going to jump to the last section that I think with ADHD we're confusing and conflating and maybe 7 different groups of people. So one are those with classic ADHD. That means strong family genetic influence, displaying symptoms early in childhood, usually by age 5, but officially only needed by age 12. Meet full criteria. Some kids outgrow it, but many of them continue to meet criteria throughout their life or continue to have substantial ADHD symptoms, even if they've dipped below full formal diagnostic criteria. And the second group, and again, there's a lot of overlap, is people who the first or many times that they're evaluated, it comes out, yeah, they have some ADHD symptoms, but not enough to meet the threshold, not enough. So they are subthreshold or subsyndromal, but then they go away to college where there's much less structure. So no one's making sure they get their homework done. No one's saying, write your essay before you go out to the party. No one's saying, don't take that substance and get so drunk this weekend that you forget to write your term paper or study for the midterm. Or when they do well enough in college, but when they go to the work world away from college, there's less support there. And also, I see people who made it through a whole working career with their ADHD, usually by finding something they particularly enjoyed and that embraced their nonlinear thinking. But then when they're faced with complete lack of structure of retirement, particularly people who are living alone and don't have a spouse. I mean, if they have a spouse, they may be annoying the spouse, but I've seen people in their 60s, 70s, and 80s getting an initial ADHD diagnosis because, again, their situation, how their brain interacts with their world, wasn't working suddenly at that point in time. There's some amount of research that actually suggests this subsyndromal at times, meeting full criteria at other times, is actually the commonest presentation, that there are some people way at one end of the spectrum who always meet criteria. But more recent research is suggesting that many people fit that criteria where at one point in time they may not meet full ADHD criteria and another point too. So moving on to the next group, which is secondary ADHD. And for years, I was a diagnostic stickler. I'd say it's important to identify this is not ADHD, this is head trauma, this is not ADHD, so there was a paper published, I think in 2023 by an Israeli group claiming that ADHD substantially increased the risk for dementia. But if you read what they actually studied, they studied people who in their 50s or older who had never met any criteria for ADHD, who suddenly developed ADHD. And in that group, if they followed them longer, many of them also developed dementia. I think the most parsimonious reading of their paper is that all they were doing was picking up the early stages of dementia, often look like classic ADHD. So when I read that, these are 2 distinct things. We shouldn't be blurring them together. Right now, I am more of the belief that what's characteristic, and I think we're going to move in this direction, what's characteristic of ADHD is impairment in these executive functions. Whether you're getting that from PTSD, whether you're getting it from dementia, whether you're getting it from another, vitamin B deficiency, whether you're getting it from contamination with plastics in your environment, whether you're getting it from post-COVID, whether you're getting it from something else, we should simply be saying ADHD symptoms attributable to or seem to be caused by, but not saying it's not ADHD at all. That's my personal feeling, but some of my other talks go into why I'm saying that. So again, a number of conditions can mimic ADHD. One of the more common ones, in addition to disease states, is sleep deprivation. So acute sleep deprivation can create an acute ADHD state, and people who have sleep apnea, so chronic sleep disruptions, often can also develop a chronic ADHD-looking state. And in many of those people, particularly the younger ones, there's some studies actually done that resolve completely when you fix the sleep apnea. So of the two types of secondary ADHD, I'd say one is the permanent one, where a head trauma or maybe post-COVID seems to affect the person for the rest of their life. And the second one is where it's clearly transitory. And the problem is often until it goes away, you don't know whether or not it's going to go away. The fifth category I touched on is that all of the symptoms of ADHD are things that normal people do some of the time, and our whole world is pushing us in an ADHD direction. So there is very good evidence that immersion in the internet makes us more distracted, makes it harder to sustain attention, makes it harder to control impulses. All of these look more ADHD-like, and I argue it's going to be increasingly difficult to discern because we've changed our world so much. But if our world is almost certainly capable of changing our prefrontal cortex, maybe it is really creating genuine, actual ADHD in some people. And then the seventh category that gets mixed in is those who are faking it, and particularly the substance abuse people are alarmed that substantial numbers of young adults, particularly young males, fake ADHD symptoms to get stimulants, or fake ADHD, or parents, and even school systems feed into this, fake or exaggerate ADHD symptoms to get special accommodations for the school or special funding from government sources for the school to provide extra services. And what I would say is, I see, and I continue to see to this day, many, many more people, both in my practice and out in the real world, who have genuine, fulfilled criteria ADHD that is undiagnosed, undetected, untreated, versus those who have no ADHD but are just faking it. And a big contingent, and it's a spectrum, proportion of those, and this has been shown in formal testing, those who are abusing, misusing both street stimulants and prescription stimulants are people who actually are substantially on the ADHD spectrum and are trying to self-medicate or self-treat. So I've thrown a lot of information about what ADHD is. I hope this gives an overview. I have a few hundred now videos out there to explain this in more detail. Thanks for listening, and stay healthy and stay happy.